let's finish off with just combination strategies in the ALK space. We talked a lot about immunotherapy in the EGFR space and the efficacy or lack thereof. Is there data, or should we be looking at immunotherapy in the ALK space? And I can say, we have some fairly consistent data that single agent immunotherapy in an ALK rearranged lung cancer, response rate is around 0. And that's not hyperbole. But we have combination strategies that we're looking at ALK TKIs with IO therapy. Is there a role for that, Jonathan? Do we think that that's something that could move forward?
So I think with immunotherapy in particular, combining ALK inhibitors with immunotherapy has been tested in a few studies. There was one recently presented the other day here at ASCO that looked at a phase 1b study looking at alectinib and atezolizumab in an ALK-positive non-small cell lung cancer that enrolled 21 patients in the treatment-naive setting. And essentially they found results that were, in terms of efficacy, that were comparable to alectinib alone, with an overall response rate of 81% and a median progression-free survival of 21.7 months. If anything, that's a bit, although small numbers, a bit less than what was observed in the ALEX trial with alectinib alone that was updated this year. And there was 62% grade 3 and serious adverse events. So, I would not recommend mixed immunotherapy with ALK TKI as a combination strategy. In terms of other combination strategies, there are some trials looking at VEGF inhibition, for example, with bevacizumab and alectinib, and there are some trials looking at MAP kinase and MEK inhibitors in combination with ALK TKIs that are ongoing, and I think those strategies, as well as the newer generation ALK TKIs, appear to have a bit more legs than combining immunotherapy with ALK TKI.
Yeah, I think we've got a lot of work to do. Certainly a lot of combinations that are rooted in scientific rationale, but we need to iron them out clinically to see what sticks. Before we move on to the next section, just a brief comment on ROS. It's another approved biomarker. Anyone want to take this in terms of just the experience with ROS and the drugs that are approved in ROS rearranged lung cancer?
Pretty easy. There's only one.
Yeah.
And interestingly, it's crizotinib, which in addition to being an ALK and MET inhibitor, is a ROS-1 inhibitor. Response rates that exceed 60%, but very interestingly, compared to ALK, the duration of disease control seems to be longer.
Yeah.
And you're seeing almost more than double what you expect in terms of median PFS with the same drug with ROS-1 compared to ALK. There are other drugs that are being investigated, entrectinib, for example. There is some activity also preclinically of lorlatinib, and we hope we hear more about that, and other drugs that hopefully in the future we'll see some type of sequential therapy for ROS-1 emerge, similar to ALK and EGFR.
One thing that I think is sometimes a little bit confusing is we often lump ALK and ROS-1 together.
Yes.
And for some drugs, like for crizotinib or lorlatinib, that may be appropriate, but not all of the ALK inhibitors seem to have good ROS-1 activity. So I know, for example, alectinib really doesn't have very good activity against ROS-1, and I don't know about brigatinib.
Brigatinib covers LORS. Yeah.
I think there's a study that's with
Ongoing.
brigatinib and ROS-1 that's ongoing.
And there's also a Korean sritinib study that was presented that shows activity.
Well, a lot to keep up with.
A lot to keep up with.
Keep up with here.